Our first speaker today is one of our local faculty, Dr. Fedorak, pediatric orthopedic spine surgeon and one of my good friends and colleagues. So he'll speak on motion-sparing surgical alternatives in adolescent idiopathic scoliosis.
Morning. I'm Graham Fedorak. I'm a local pediatric orthopedic surgeon. I work at Kapilani, the Children's Hospital here in Hawaii. And we're going to talk about non-fusion options for scoliosis. Are there any other pediatric orthopedists here? Okay, it's lonely. Is there a clicker? Okay. All right, so we're going to review motion-preserving alternatives to spine fusion for scoliosis patients. There's really two categories at this point in time, vertebral body tethering and the PD3, or the posterior dynamic distraction device, which we'll talk about pretty briefly. I always do this whenever I talk about adolescent idiopathic scoliosis, just a PSA. Early identification of these curves, bracing earlier than maybe you were taught when you were in training, can lead to a whole lot less surgery, which at least as a pediatric orthopedist is sort of our goal. We're trying to keep as many of these kids out of the ORs as possible and leave them for your OR when they're older. So here's the history of pediatric spine surgery in a nutshell. We did fusions, and there were also fusions. These were all effective alternatives. But the rationale for surgery is sound. We know that big curves continue to get worse after growth ends. We stop the progression of those big curves by fusing the spine, and the bonus is that we get to correct the deformity as well. However, there are downsides to a spine fusion. There's a loss of motion, which is quite substantial, as in all of it, and then loss of growth, which I would say is rarely significant, but for some of our shorter or younger patients, it's more of a factor. And when we're talking about these alternatives, it's really important to point out that fusion is still the gold standard, and it's much more immediately gratifying than vertebral body tethering as a surgeon. We know that fusion is a tried and true procedure with a great track record. It's safe for a major surgery. Whenever we're going to talk about reoperation and complication rates for a new procedure, it's important to have a reference. I think the HARMS 10-year data is a pretty good starting point, showing a 9% reoperation rate over the first 10 years after surgery and a 12% major complication rate, which compared to what you folks have to deal with your adult patients is probably no big deal. So fusion works, it's pretty safe. The question is, why would we do anything different? Well, it's not perfect, and the perfect scoliosis surgery would have all of these things. It would be predictable and safe. It would have a low reoperation rate, low complications. We'd be able to straighten the spine maximally. We'd be able to maintain or maximize spinal motion and maybe even allow continued growth. But where we're at right now is that nothing that we have does all of these things. And so in a patient-specific era, we have to be patient-specific, and different folks are going to have different priorities. For these people, preservation of motion and growth probably matters very differently than it might for all of our patients. So here's the two non-fusion options which are available right now to my knowledge, both of which were approved in the summer of 2019, the vertebral body tether, which I think has a pretty extensive experience at this point in time, and the posterior dynamic distraction device, also known as the APIFIX, which has less experience, I would say. We've been tethering in Hawaii, my partner, Dr. Burkhalter, and I, for about 5 years. When I was at the University of Utah, I got trained kind of in one of the early cohorts right before COVID hit, and then moved here to Hawaii and got started tethering in kind of July of 2020. So the basic idea is that this is a non-fusion option. It's minimally invasive, done thoracoscopically in the thoracic spine. It is motion sparing to an extent. And what it really is guided growth of the spine. So the principle of guided growth means slowing down the growth on the long or convex side of the curve, harnessing that growth remaining on the concavity and allowing kids to grow out of their scoliosis. I highlight grow because it's really, really important. There are certainly folks that are doing this in skeletally mature individuals, and that's okay. They can do that. I'm not sure how it makes sense. So we have done this for decades in peds ortho. Guided growth, seen here for a child with genu valgum, medial distal femoral hemiepiphysiodesis, tension band plate. They're going to grow out of their deformity over about 12 to 18 months. This is a well-established thing we've done for 50 years. And over the last 20 years, people have kind of brought this technique to the spine. So we're using the Hutter-Volkmann principle. Compression is going to slow down growth. Tension is going to accelerate growth or allow more normal growth to resume. And we do this in the spine with differential forces on the convexity and concavity. It's pretty straightforward. We put screws on the convex side, and we have a rope which we tension, pulling those screws together to change the direction of the forces. So we do this thoracoscopically down to about L1. At our center, we use a pediatric general surgeon just because it is an infrequent case. And I think that, as an orthopod, we scope tons in our training. We're all pretty comfortable with the scope. And sometimes when the general surgeons are doing it, I'm like, no, I want you to go there, go there. But I think if there ever were a problem, just from a liability perspective, having them involved is important. I do a lot more thoracolumbar and lumbar tethers, despite that not being the consensus approach for how to start doing this, just because I think the motion matters a lot more. And anything below L2, we tend to do with a small anterior retroperitoneal approach. So you release the pleura, you ligate the segmental vessels, figure out your screw position. Here's an example of a way we use fluoro to target our shot. People are navigating this. Noel Larson at Mayo is probably the person who's done the most research on using navigation for tethering. Next, you're going to place an awl with a staple, and then you're going to tap. You're going to measure as you tap, and then place a screw. Pretty straightforward. Rinse and repeat at each of the levels. And then you're going to tension the rope sequentially, level by level. Typically, no tension at either end. We actually leave a little bit of a loop, and then maximal tension at the apex. They have this tensioning device, which is completely superfluous, I would say. Most of what you're trying to get with your correction is going to involve bolsters, which we take out when we're going for our correction. It's going to involve direct pressure on the vertebral bodies with our all-in-one device. And then we use this to get the last little bit. So the numbers on it don't mean anything. Post-operatively, we leave a chest tube in for 2 days. That was based on recommendations from Dr. Samdani and the folks at the Philly Shrine, not to try to take it out the first day, which is ironic because now our spine fusions, which go home kind of afternoon of day 2, are staying in hospital longer than our tether patients, which is a lesser procedure. Narcotics are uncommon after the chest tube comes out. It's usually just ibuprofen and Tylenol. These kids are back to school 2 to 4 weeks. The thoracic tethers, I have no restrictions at 6 weeks. The lumbar, I slow down a little bit just because I want to give the abdominal wall musculature a little bit of a chance to heal more solidly before they're getting back to sports. But a lot of them don't listen, and they go back to doing things pretty aggressively pretty quick. So here's a good candidate, a very Hawaii candidate. This is a 14-year-old kid. He's a bodyboarder and a surfer. I think this was case 2 for us 5 years ago at this point in time. He had a 45-degree thoracolumbar curve. He's Sanders stage 3, plenty of growth remaining, and this is just going to get worse. So he has a flexible curve at a curve location where preserving motion has more value. Here's his post-op film. The goal is not straight post-op unless you're doing this on somebody who's at the outer edges of skeletal maturity for this procedure. Otherwise, they're going to absolutely overcorrect. Excuse me. So here he is, again, post-op, and here's his 3-year final follow-up. He's coming back, I guess, in the fall for a 5-year follow-up. Looks pretty great. So shouldn't everybody get this? My answer would be 100% no, and I would tell you that most patients, in fact, should not. But the whole point with these procedures that we now have is that it's not just one size fits all. You can get a spine fusion, and if you don't want a spine fusion, come back in 6 months and maybe you've changed your mind. It's people need to be presented with these options in a timely fashion so that they can make the best choice for them given their particular interests and goals. So I'd say scoliosis surgery decision-making requires a lot more nuance now than it did when I was in training. We know that a fusion is a much, much more consistent procedure. You know what you get on the table. Again, complications are relatively uncommon. We, without question, get better deformity correction, particularly in terms of rotation. We lack long-term follow-up for these tethering procedures. There's a couple 5-year studies that I'll talk about. I've heard John Braun talk about his 10-year results, but there's not a whole lot of long-term follow-up studies out there. So we don't know what the future holds, although we can kind of guess. There's a roughly 20% reoperation rate, and that's at about 2 years. And if you want to compare that to 9% at 10 years for a fusion, that's obviously a huge, huge difference. There are also very valid questions about how much motion is actually preserved that we'll talk about a little bit. And then there's the fact, where's the curve located and what does this person do? For me, these are the biggest factors. Is this a thoracolumbar or lumbar curve? I'm going to lean more tether. Is this kid an athlete? What kind of an athlete? If they're a basketball player, I don't know if it matters. If they're a surfer or a golfer or a baseball player, somebody where spinal extension or rotation is that much more important. I've got a couple surfers in my practice that they're going to get something at some point in time. The families know that, and really they want to keep surfing, they want to keep moving. I don't know if that's particularly straightforward after a long spine fusion. So success is variably described in the literature as a curve less than 30 degrees or less than 35 degrees at final follow-up. And there's a huge variance in terms of that, hitting that number, anywhere from 52 to 90%. What I would say that for a lot of these families, when you talk with them, success for them is avoiding a spine fusion. And whether that's reasonable or unreasonable, because we all think spine fusions work pretty well or we wouldn't do them, that's success for a lot of these families. Most newer series would quote you around a 75% success rate. Success, again, in quotation marks. I think we're getting better at patient selection, and 90% plus of these kids avoid a spine fusion so far. So just two studies really briefly. This is Dan Horschmeier's recent study from JBJS where he updated work that he had published a couple years previous, looking at kids now at 5.7 years after their initial surgery. He only lost one kid from his initial cohort. His success rate, defined as a curve of 30 degrees or less, went from 74% at 3 years to about 64% at 5.5. He had a 24% revision rate. However, 93% of those kids had avoided spine fusion, and in talking with him and other people who've done this for longer, most of these families who are quote-unquote failures are still very happy that they haven't had a spine fusion. This is the only other sort of 5-year study that I was able to find. The folks at the Philly Shrine published this a few years ago, an 80% quote-unquote success rate with a 12% reoperation rate. The real caveat for this series is that a number of the curves that were treated earlier in their experience were really small, and nobody would think about tethering them at this point in time unless they were getting paid all cash or something like that. It's pretty unreasonable. So there's three main reasons that people have reoperation. And when you're talking with families about the risks and benefits of a procedure, you're obviously going to go through everything. But these are the three that I spend the most time on. There's overcorrection, which I often will frame for families as evidence that growth modulation worked. We've released 3 tethers so far. It's easy, it's straightforward. Even for thoracolumbar tethers, which are all 3 that we've had to release, we typically just go back in thoracoscopically and release them at 10, 11, 11, 12, 12, 1, which we can access pretty easily, and we don't have to open up our anterior approach again. There's failure of the tether and needing a fusion. We've done 1. Most people that I talk with at meetings have done 1 or 2. And so this is typically a curve that was too big for the tether, or you didn't get sufficient correction, or you picked a bad candidate. The anecdotal experience from folks is that fusion is relatively straightforward. When we did ours, there was 1 screw that I felt, and I just redirected my trajectory to an anatomic one instead of straight ahead. Great, no big deal. So the other thing is tether breakage requiring a revision of the rope. This should get less common once a better rope is available. And I know one of the companies has a better rope, but I don't like their system as much. The other company's working on a better rope, but I do like their system. This is, again, more relevant if you pick your patients poorly, which I would say is a patient that doesn't have enough growth left to growth modulate their spine. Lumbar tethers are more common to break. A lot of folks are doing double tethers now. We do that every time we can if there's enough space. And that might just mean a double row at the apex over 3 or 4 levels. So valid questions about how much motion is actually preserved. Noel Larson's done a couple of x-ray studies on this. The first was looking at the thoracic spine. The second was looking at the lumbar. Flexion extension is reasonably well preserved. Thoracic tethers preserved a 20-degree flexion extension arc. It's not huge, but it's pretty good. Side bending, however, everything in the coronal plane is minimally preserved. So preoperatively, these kids would bend a 30-degree arc of coronal motion down to about 7 degrees. So minimal preservation of coronal motion. In the lumbar spine, it was a little bit better. Again, the lumbar spine moves more. So 30-degree flexion extension arc was preserved and side bending was roughly halved. This is a really cool study that Josh Pays at the Philly Shrine did, looking at using motion capture technology. This is super busy, and I don't want to get into it too much, but in general, thoracic extension is pretty well preserved, which I think has implications, again, here in Hawaii, if you're a surfer or a bodyboarder. Side bending was minimally preserved. There wasn't a huge difference. but there was a huge difference in terms of rotation. And if your kids are athletes and they need to move through a flexion extension plane, they need to rotate as a baseball player, as a golfer, I think that preservation of rotation has real advantages. And for anyone that's played sports, we're not doing a whole lot in the coronal plane. It's rotation coupled with flexion extension. That's sort of the heart of it. And tethering preserve normal rotation. So in summary, you want to be really patient specific. Here's just my general algorithm for how I think about these things. Are they a high level athlete? Is it a rotational sport or a sport where extension is required? Going back. Where is the curve located? Is it in the thoracic spine or the lumbar spine? And again, what are the patient and family preferences? We hear about patient-specific medicine and personalized medicine and all these things, and I'm a huge believer in that, and I think this is just an extension of those concepts. Here's evidence of reoperation, but I would not call it a failure. It's more a proof of concept. This is a 12-and-a-half-year-old ballet dancer, 44-degree curve. This is her life. This is what she loves to do. It's really, really important to her. That doesn't work well with a spine fusion. So she's Sanders 6. She was certainly on the more mature end of the spectrum. So we went for more correction. And here she is at a year post-op, at which point she's overcorrected. A release was recommended, which she declined. And then 5 months later, so we're now a year and a half post-op, a release was again recommended and she agreed. Here she is 6 weeks post-release, and then here she is a year post-release. You can see where this arrow is here. The screws have splayed, which is our proxy for the rope has broken. And when we think about those limitations in terms of the coronal motion, with those studies looking at motion, either X-ray or in the motion capture lab, what I anticipate is that over time, that coronal motion is actually going to get better because we're planning on that rope. It's going to break eventually at some point in time. So these kids move really, really well. Here she is, sagittal profile. You would anticipate with an anterior procedure that they're actually going to become more kyphotic. She actually got better. She looked like she had some thoracolumbar kyphosis prior to surgery. And you can play with this a little bit by varying the position of your screws as you're putting them in. And that's her in the Nutcracker a couple years ago. So this is an option when the curve, in my mind, when the curve's 40 to 65 degrees. I like it a lot better when the curves are smaller, sort of 45 to 50 degrees, when you know where it's going at some point in the future. They have to be flexible. If the curves are inflexible, it's not an option. It's really, really important. Kyphosis is a relative contraindication, obviously. And then skeletal maturity, it's a Goldilocks kind of thing. They can't be too immature. They can't be too mature. You have to thread the needle. And all of those other factors in terms of what that family wants and what that patient does with their life are going to weigh the scale a little bit differently. I don't like doing a Sanders 6 kid like that last kid. But it was really important for her spine to move, so it was an option, knowing that you really haven't burnt any bridges if it doesn't work out. So very, very briefly about the PD3 or the ApiFix device, posterior dynamic distraction. This is a self-adjusting ratcheting rod, which allows the device to continue to expand. The original hope was that you would put these in, do some side bending exercises, and it would ratchet out a little bit more every couple weeks. So far, what we're seeing is that it tends to just keep up with growth. So the correction that you achieve at the time of implantation is what you're hoping to maintain in the future. There's a polyaxial joint that allows quite a bit of spinal motion. It's a really neat design. There's some studies out there with not great results. These are older iterations of the device, which they've improved. So I think if you're looking through the literature, you have to be really clear on what iteration of the device are you reading about. This seems better. This is a super easy surgery. I've done one, and then I think a couple months later, the folks at Shriners did one. So there've been 2 in Hawaii, to my knowledge. It's super, super easy. The company is doing a really good job with registry data. So I think we are eventually going to have some good quality data. And they provide an update every month for those of us that put these in. For a good tether candidate, I wouldn't say you should do this instead of a tether. I don't believe that yet. And in talking with people, the results for a Lenke 5 curve have been much less good than for Lenke 1s. This is a match study that came out in Spine Deformity earlier this year. It showed lower blood loss in the PD3 device. The blood loss was so low in both cohorts, though, that it's sort of a whatever. The surgery was faster, 2 hours versus 3. When we're doing something that's for somebody's whole life, I don't know if saving us an hour is that relevant. This is for their entire life. We just need to do what's best for them. But I'm interested at this point, there's actually better correction in the PD3 device. It's a small difference. It may not even be significant. It's 5 degrees, but that's interesting. And this is the thing that puts me off a little bit. These match cohorts, the tether folks are good at picking their patients. They're benefiting from that increased knowledge that we've had over time. They had a 5% reoperation rate at 2 years versus 15% in the PD3 device. And at some point in time, this device is going to break. It's metal. It's got a polyaxial joint. At some point in time, it's going to break. And in talking with some of the advocates for the device and the folks at the company, they're like, oh yeah, just leave it in. Like, cool. But then what happens? At some point in time, they're going to feel crack. They're going to run into the emergency department. There's going to be a broken hardware. And then you have to do a surgery on a more expeditious basis. And so I just don't believe that this can stay in forever. And I might be wrong. The one that I put in, I told the family, I'm going to take this out at 5 years. It doesn't make any sense that you can go through your whole life and just leave this thing in. But 5 years from now, we're going to have 5 years more data so we can make that decision together. So here's that kid. She was 13 years old. She came in with a relatively modest curve. She really struggled with bracing, really struggled. Curve progressed to 40. MRI was unremarkable. The family had very strong feelings against spine fusion, which I think we all know happens when you have a family with a teenager with scoliosis who has an 80-year-old grandparent who had a really, really tough surgery that went poorly. It's not the same thing, but in their mind it is. We talked about the options. I really didn't push tethering for this kid because I didn't feel it was a huge benefit for her. She went and read about everything and they chose the PD3. She had a lot of back pain as well, like much more than we normally see with scoliosis. And interestingly, immediately post-op, she felt great. Her back pain was better. Here's her x-ray, and it's kept up with growth. So there's no right answer at this point in time. I think when you're taking care of these kids, a thorough discussion of all the options. These are all my patients: fusion, tether, PD3 or ApiFix, and then this is an example of a hybrid fusion thoracolumbar tether for a kid who really wanted rotational correction of her thoracic spine. That was really important to her, but she's a surfer. And so we wanted to maintain some motion, so we did a tether through the thoracolumbar spine. So these are my kids. I think most kids are better with fusion. My kids do things like gymnastics and aerial silks. If they were my kids, I would tether, but it doesn't really matter what I would do for my patients. Families always or for my kids, families always ask us that. It's what do you value? What's important to you? How do you want to move your body? And how comfortable are you with a new technology that we don't have long-term follow-up for? Lots of options, lots to talk about. Mahalo.
I'll start with a question for you, Graham. Terrific talk, terrific overview of those two motion-sparing techniques. Certainly the bar, I think, for thoracic scoliosis is fairly high, since a selective thoracic fusion does so well in most people's hands. That the thoracolumbar and the lumbar curves, I think most would agree, is where there may be more bang for the buck or more of a need. And so my question for you is, what is your prediction in terms of time, number of years, and what challenges need to be met for us to consider a thoracolumbar tether as a standard of care for, say, a Linky 5?
I don't know that it will ever be the standard of care. I really think, I don't think it's the perfect surgery yet because it's so unpredictable. If we were able to get really accurate information about exactly how much growth do you have left, exactly how tightly are we tensioning each of those levels, exactly how much wedging is there at each of those apical segments, we might be able to create some sort of an algorithm that would tell us, you're going to get it to X at this level and Y at the next level and Z at the next. And then 6 months later, 12 months later, this is where you'll be at. The numbers are huge though. And one of the challenges is even just tensioning the tethers. They show that little gauge that you're supposed to look at, which is total garbage, right? It just is. It just is. And early on, people would say things to me like, okay, you want to level the disc spaces. I mean, maybe if they're a Sanders 3, I might want to level the disc spaces. If they're a Sanders 6 and I don't have a lot of growth remaining and there's wedging, I want to harness that growth modulation as early as I possibly can. And so I'm going to crank on it and get the disc going the opposite direction. So I don't know that it's ever going to be predictable enough that it becomes the standard. I think that what's going to happen in the future is that as people get more comfortable with this technique, and you know, at the meetings, people are getting more comfortable with it. You know, Dan Ciccato at the last POSNA meeting didn't get up and yell that like tethering's the devil. You know, he was like, oh, there might be a role for this. Whereas at previous meetings, a lot of people would say that it's terrible. I think it's going to be based on what people do. Athletes, they're going to go in that direction. A lot of our patients aren't athletes, right? And a lot of folks are uncomfortable with uncertainty and they just want a nice, predictable, solid procedure. Sorry, that was a long non-answer, but it's just a convoluted way of saying I don't think we know.
I think the challenge sometimes is when we think about shared decision making. As a surgeon, we say, oh, well, we involve the patient and family in this decision. But the challenge is a lot of patients come in with the assumption or with the dogma of, I don't want a fusion. And they really don't understand that operation. They may think about, you know, aunt or grandma who's had it, and it was a very different operation 30, 40 years ago. And they say, I don't want that. And as soon as they enter the office and they say, I don't want a fusion, it's hard to really say that you've really engaged in shared decision making when they're coming from a place of, you know, a little bit of ignorance. And then when you drink the Kool-Aid and you go out there and you say, well, why would you ever fuse your child? It's hard to really bring them back to the center and really look at the data and call that truly shared decision making. And that's something, you know, when I have that discussion, it's very clear, you know, when you think about the, you know, with the internet and blogs and these groups that moms and dads can be a part of, they come in already pre-treated.
Yeah.
And I think it's on us to really bring them back to the center and level set and say, you know, here's what we know. And really, you know, they don't know. When you talk about complications with a patient and family, they don't ever see that as being something they'll ever have to deal with. Absolutely. When you have an infection or something, you can tell them about that data. But when that patient gets an infection, they're like, well, how could this have ever happened?
Yeah.
You know? And so we just have to be responsible when we do these types of operations, because sometimes we say that the patient and family wanted it, but I'm not sure if it's responsible to say that sometimes, because they just kind of, they're so malleable that we have to understand that. And
no, those are absolutely great points. I think I really feel strongly about this procedure for thoracolumbar curves, and that's 80% of what I've done.
Yeah.
And the thoracic curves I've done have been very sport related, I would say. And I've had a number of patients, I think 3 or 4 that I can think of now, where I've just said, I don't think you should get a tether. I think you're too mature. It's a thoracic curve. The things that you want, like they really want nice rotational and coronal plane correction. They want their spine to look perfect, the cheerleader curves, right? And I've said, you're not going to get that with the tether. You're going to get that more reliably with the fusion. And I've had a number of those patients go to the mainland and get a tether, and then some come back with issues. But like, I think that you have to stick to your guns as well, and not just cave to putting these devices in patients because that's what they want if you don't think it's a good option. Yeah.
Nice talk. Thanks.
Yeah, Graham, terrific talk. Thanks for, I think that was the most balanced perspective I've seen, something that's really a divisive issue. And I had the chance with John Emmons at Boston Children's. We actually reviewed the series from Philadelphia Shriners, mostly Amir Sandami's cases. And it was quite remarkable how few complications there were. And a lot of them that were complications, for example, overcorrection, breakage of a rod that was asymptomatic, I honestly wouldn't have considered a complication at all. I thought those were fine outcomes.
I'm trying to be balanced. I think this procedure goes well. And when things happen like overcorrection, I'm like, okay, I can fix that. It's straightforward.
My question is, we had a talk that we should bring back at some point, because this is such a unique audience about the pediatric and adult population, or pediatric and adult surgeons working together and learning from each other. And I've talked a couple times about the issues of pediatrics, or what becomes an issue into adulthood, so the transition between pediatrics to adulthood. And I think this is a really important consideration of, I think a lot of times thoracic curves are overcorrected. Our type A lumbar modifiers, I think a lot of times really don't need surgery, especially in a skeletally mature kid, because symptomatic thoracic deformity really isn't a big deal in the adult when you've got a type A lumbar modifier. But I think what you're pointing out here is our thoracolumbar curves really do become an issue. The fractional curves become problematic. And the idea of actually being able to correct these with preserving motion, I think that's where there's the best opportunity. And what I'm interested in is how can you maybe do a better job? Your case was a good one, but of really trying to get some lordosis when you get into L3 or below. How can you technically perhaps be a little more lordogenic? And would you ever think about like doing apical fusion and then tethering, or something that might actually enable a little more apical lordosis?
I have not. I sometimes do my lumbar fusions or thoracal, like Lenke 5s. I sometimes do them anteriorly, kind of twice a year. I'll still go in like old school, which was before my time, but just so I can save a level. And, as John Hall described, I don't know how many years ago at this point in time, that 3-level fusion where you overcorrect it. I've done that as well. It's a neat idea, like trying to couple those two things. And I guess if you were going to do that, could you just do a 3-level fusion and you don't need to tether at all, right? Because scoliosis, some people say it's like a 3-level disease, right? There's going to be 3 apical levels of wedging, and then everything else is a product of that. And so I don't know if, we're there anyways. We've got it open. It's an interesting thought. I don't do research anymore though. I'm just here in Hawaii, like living my life, but it's a really interesting thought.
One more question for you. I guess along those lines, some have advocated posterolateral sort of Wiltse interval placement of fixation. I think with this device, it's off-label. But what are your thoughts about?
Super cool. Yeah, I think it makes sense. And I remember when Dr. Lahner was here a couple of years ago, I asked him about, can we put in tethers for kyphosis? And he described there's a series from Turkey where they've done that. And I think there's lots of cool off-label uses that potentially make sense. And certainly if you did that, it's going to address the sagittal plane concerns. None of us like looking at a lumbar spine that's so straight, even if it is just down to L3. Yeah, it's neat.
And then finally, just since, in my practice, I do see peds, but I look at the various growth assessments. So the hand film, the Risser grade and so on, mostly to inform bracing, but certainly you have in your practice, when you're trying to time a tether, you need a little bit more granularity along that,
It's one of many variables. Yeah.
Yeah. So how would you compare and contrast those modalities of assessing growth, and why do you choose Sanders over the others? I
just choose Sanders because when I go to, SRS and POSNA and stuff, that's the one that most people use. I think there's a lot of incongruities between Risser and Sanders. Sanders is just a more reliable, and there's a bunch of other things you can do. Somebody will put out a paper every couple of years. You can use the shoulder, you can use the knee, you can do all sorts of stuff, and that's cool. But I think most people are using Sanders, so I just use that so I have a common language. And not to get into the weeds too much, but the Sanders 3A versus the 3B, right? When they've just gone over that peak in terms of their growth. For me, a Sanders 2 is probably too early for a tether. And that's an opportunity maybe for an apifix if you're trying to help somebody avoid a fusion and they're like 8 or 9. And then a Sanders 7 is too old. Cool.
Right.